We are live.
A warm welcome to all of our attendees joining us from around the world to this exciting webinar this evening. Today, we have a very interesting topic titled AI Protecting Vision, Revolutionizing Early Detection of Silent Sight-Threatening Diseases. And today, we have a wonderful esteemed panel of speakers who are going to be sharing some insights and new developments in the cutting edge tools that are being developed to assist us as ophthalmologists to deliver care. I'm going to be your host for the webinar and the moderator today. I'm Dr. Anthony Vipindas, a senior consultant ophthalmologist and a task evangelist at Remedio. And in my previous avatar, I was developing large EMR systems and working on big data. Today, I wanted to set the narrative of the webinar. And I want our attendees to remember 4 R's. The first R is relevance. There is a great opportunity for us to look at the unmet need in terms of diagnosing ocular diseases in a more efficient and an accurate way. And what are the most relevant problem statements and use cases that we as ophthalmologists are able to identify to develop AI algorithms? The second R is research. And why is this important? It is important for us to generate enough evidence to be able to confidently trust the AI algorithms that are being developed to assist us in the delivery of eye care services, both in terms of screening or in clinical practice. The third R is regulation. And I think today it's going to be very important for us to understand that software as a medical device is right now here to stay. Medical devices, ocular diagnostics, usually, used to be hardware, but even now software as a medical device is an evolving new concept. And regulation is very important for authorities to be able to approve these algorithms after they have actually proven their accuracy in real world settings. And the fourth R is reach. It is very important for us to be able to bring these algorithms to the point of care. And I think here lies the great opportunity for us to really redefine the way we deliver care, redefine the way we identify ocular diseases, not just identify them, using AI, identify them at an early stage so that we are able to preserve vision and sight. And this evening, we have 3 of our esteemed speakers who are going to be talking about aspects that are related to diabetic retinopathy screening, the use of these tools in a real world setting, and also touching on glaucoma screening as well. It gives me great pleasure to invite our first speaker this evening. I'm very pleased to introduce and invite Dr. R. Kim, the Chief Medical Officer, Senior Medical Consultant, Retina and Vitreous Services at Arvind Eye Hospital, Madurai, to kindly deliver his talk on diabetic retinopathy screening in India. Dr. Kim?
Thank you, Dr. Vipin. At the outset, I want to thank Dr. Nandra for creating this and Remedio for organizing this webinar on a very, very important topic, both AI and diabetic retinopathy. So my talk will be limited to diabetic retinopathy screening in India. So let me share my slides.
So I think I would like to thank the Remedio, the Arvind Eye Care group of hospitals, as well as Sun Pharma and all these speakers who've made it today. And I'm sure it's going to be a great scientific treat. And I think artificial intelligence is the way to go. And who can do it better than the team, who's sitting here. So thank you so much for doing this. Dr. Kim, all yours.
Thank you, madam. Thank you. So we can see my slides.
Yes.
So the title of this topic was AI protecting vision. It's a very interesting topic, but how do we do it? So it's very important. And one of the major problems that we all have and we're all aware of is diabetic retinopathy. I'm sure all of you have seen this slide multiple times, how diabetes is so prevalent globally. And it's so scary. Till last year, we were thinking this 21, we were thinking it was 467. But now the IDF has shown it's 537 and it's projected to increase to 2045. And so in India, uh, the prevalence of diabetes has been increasing over the last few years, more so for we all know the reasons. We can call it urbanization and the change in the way we are doing work. Now we have, when we thought it was 71 million, today we have already reached the target of 2030. That is 101 million diabetics in India, which means we are having a huge problem related to diabetes complications, which as ophthalmologists we have to face. Some of you, many of you may be aware of this multicentric study that was done in Smart India, where we did cross-sectional across the country, trying to find out the prevalence of diabetic retinopathy by 20 different centers spread throughout. And it showed the overall prevalence of diabetic retinopathy was 12.5% among the diabetics above the age of 40. But what's scaring is the overall prevalence of sight-threatening retinopathy in these patients is almost 4%, that is almost 3 million, which means these 3 million are likely to go lose their vision if not attended to early on. So we really need to find ways to address them or find them first. It was also found in this study that the prevalence of diabetes and diabetic retinopathy was both. The earlier it was thought it was just urban, but we know now it is almost equal in urban and rural areas. The scary part is in rural areas we have very little access to these specialist care, and unlikely that these patients will get access. So how do we address them? And we all know that it is very important to diagnose this early on before the vision is lost. And definitely the treatment is effective only when you identify these patients early on and not when they've already lost their vision. And unfortunately, many studies have shown that 45% of the patients with diabetic retinopathy going to the eye units have already lost their vision before the condition has been even diagnosed. This shows that we are not really doing much, and we have to address this early on. Why all diabetics should be screened for diabetic retinopathy? We have been doing a lot of screening camps, and we have, in our experience, if we see 100 diabetics at a time, only 20% of these diabetics will have any diabetic retinopathy. And of these 20%, only another 20% will have vision-threatening condition. But since we do not know which 20% we will have to, we will be having the sight-threatening retinopathy, we'll have to examine every single diabetic at every single opportunity that is possible and ensure that every diabetic is screened at least once a year. So these diabetic screening camps working with the local physicians has been helpful, where the physicians identify the diabetics and the ophthalmologists are able to look for diabetic retinopathy among us. This is one such camp which is done regularly, where the diabetic part is done in the general population by the diabetologists, and those identified by diabetes have been screened for diabetic retinopathy specifically, only for screening for diabetic retinopathy, and if identified, they are referred for further management. So this helped us to develop this guideline for comprehensive management in 2008 with under Vision 2020, which showed how to screen for diabetes. And subsequently, multiple screening guidelines were brought out. The recent ones was from the All India AOS that Das and the team had shown who should screen for the diabetic patients. how should they be screened, when, at what point of time should they be screened, what are the tests that needs to be done for these patients, and what is the referral mechanism for them. But the key factor in diabetic retinopathy management is the identification of these patients early on. How do you do it? Only by early screening, because these patients do not access care unless they lose the vision. So telemedicine has come in with the use of technology. This is a really good boon to give access to people who don't have access to specialty care, and also the address the lack of trained human resources. So screening for diabetic retinopathy can be done in the physician's office, who the patients are seeing for the first time. So the diabetologists see these patients, and the diabetic patients do not go to the ophthalmologist, but they definitely go to the physician's office. So just like how they get their blood investigations done in the physician's office, they can have their eye screening done using technology, and what we call this as opportunistic screening by using telemedicine, where the patient's fundus images are captured by the technician in the physician's office by using a fundus camera. Over an internet, it can be sent to a reading center in the eye hospital, where the retina specialist can look at these images, generate a report, and send a report back to the physician's office within about 1 to 2 hours. So the physician or the diabetologist can explain to the patient if they have their eyes affected, they can be referred to the ophthalmologist earlier. So this way we've been able to pick up patients much earlier. So with these background, the recent guidelines were published in 2020 by All India Ophthalmology Society and the VRSI combined together. We published this, which showed what are the things that needs to be done for diabetic retinopathy screening, like how do you do these screening, how often, what are the different screening models that are available, who should do the screening, what are the fundus cameras that can be used, what are the number of fields to dilate, what are the governance and quality assurance that is needed, what is the IT infrastructure, and more importantly, in the recent times when artificial intelligence has come in, how do we use it responsibly? And it also included public awareness and how do you control risk factors. So how do you train people for this, doing this retinal photography? There have been different guidelines have been laid out. I'm not going into those details, where each one at what level of learning that these different technical people should be doing, or knowledge they should have in doing the DR screening. And what do you mean by good quality pictures? How do you define which is good, which is moderate and poor quality? All these are explained in these screening guidelines. But what was found in this process of screening, manually screening these patients and then manually graded by the either trained graders or retina specialists, was the time taken by the retina specialists or the trained graders to do this grading. There's a time delay in doing this grading, but more importantly, in one of the studies we found there's a lot of inconsistency in the grading among the different graders. So how do you overcome that? One of the solution that was seen was the use of artificial intelligence. Way back in 2015, we started working on it, and then this has come into use now. We have multiple algorithms. This is one of the algorithms which shows within a few seconds you are able to have different grades of diabetic retinopathy by just exposing this image to that algorithm. So today we have replaced this grading by the retina specialist using these AI tools, so that physician need not wait, and it is available 24/7, 365 days whenever the physicians want to do the screening. So multiple validation studies have been done, and it has been shown that the performance of these AI is better than the trained grader or a general ophthalmologist, or sometimes even better than a retina specialist. So we continue to use this since 2019. Uh, what did we see when we looked at 1 year data, when we screened 232 lakh 35,000 patients for DR, the numbers identified for diabetic retinopathy was around 1,000. Whereas when we started using, the number of diabetic retinopathy number steeply rose almost by 6 to 7 times. This showed the power of AI, how it can help in increasing the identifying these patients early on and in a larger number, which we probably are missing by just manual grading. So there are a lot of these guidelines showed when these patients should be screened, when how often these patients should be referred. All these gave ways or guidelines to do the DR screening and refer the patients as per the time that is needed for referring them. In the recently, we also worked with the RSSDI, the Research Society for the Study of Diabetes, along with the Veterinary Society of India. We came out with the screening guidelines. This came in January recently in 2024, which is a position statement that gives the guidelines for the physicians because they are the first point of contact for the diabetic patients. So how they can screen the patients in their own office and how they can promote the awareness among diabetics who are visiting them. So this is a joint publication that was done, which gives an idea for these physicians on DR screening. Recently, we are also launching this program called Drishti, are both RSSDA and BRSI, which is diabetic retinopathy screening tool for India, which is being supported by Sun Pharma and Remedio. This is across pan India. We are planning to deploy. The objective is to sensitize physicians about diabetic retinopathy screening and timely referral, creating a physician-based self-sustaining model for DR screening. We are creating some multiple units where the physicians are connected with the local retina specialists so that there is a complete loop is taken care of where identified patients can be referred to the to the retina specialist for further management. Connect physicians with vendors to help setting up screening models, conduct DR screening in their physician clinics, and more importantly, raise awareness about diabetic retinopathy among the physicians and their patients. So this was recently launched. There was a big public press meet that was held in India, in Delhi last week, to popularize this among the public. So in summary, the DR can occur in any person with diabetes, physicians being the first point of contact for any diabetic. They play a vital role in DR screening and can do a timely referral to the retina specialist for the management and follow-up DR. Sight-threatening DR is definitely an avoidable cause of blindness and can be avoided if identified early. And more importantly, the recent times we can see that AI can play a major role in assisting physicians to identify early diabetic retinopathy and also with the prediction and may be able to there are newer tools that are coming in that can predict if these diabetic patients are likely to develop diabetic retinopathy or not. But these are all work in progress. But we will soon see them in use with after multiple validation studies. So thank you again for this opportunity to share this with all of you. Thank you.
Thank you, Dr. Kim, for an absolutely wonderful presentation. And I'll just kind of summarize, and you touched based on all of the aspects of relevance. You know, the need of almost 780 million diabetics worldwide, 20% having diabetic retinopathy and 20% having sight threatening. You've so beautifully shown the evolution of the CAM screening, to telemedicine, which took an hour, to now using AI tools that you've developed to bring it down to a minute. And a 647% increase in terms of identification of people with diabetic retinopathy truly shows the power of what technology can do for early detection. And I have a couple of questions, Dr. Kim. And of course, all the stalwarts like you with scientific research that has been done have led to the development of guidelines. How do you see AI assisting in creating or refining these guidelines? Do you think that the use of AI, because you've seen that knowledge that probably you would have got at 1,000 patients versus what you would, get at a much larger number, do you see AI assisting us to develop even more better guidelines moving forward?
Definitely, because one, this AI can help in uh, precise and personalized screening guidelines that can help because of the data, the vast amount of data that it is working on. It'll help us to identify this and also assess in individual risk factors and disease progression, allowing for dynamic and personalized disease screening intervals. It can also contribute to more cost-effective screening strategies because of using AI. Those are a few things that I think will
No,
be
I think we've really touched the most important aspect of personalized screening and personalized advice and treatment plans, because you know that on the health economics bit, with the pot of gold that we have, how do we ensure that it is used most effectively to reach the patients that need to be reached? The other question I have, Dr. Kim, which again you so beautifully showcased about the beautiful partnership with the industry that you've launched, the Drishti program. And how do you basically see this as helping scale the guidelines of screening for diabetic retinopathy with the physicians? I think it's an excellent, fantastic model for the country where there's a cross-disciplinary implementation in another specialization of medicine, but you're actually using technology for detecting the disease early so that referral can be done. Can you elaborate a bit more about the potential for this kind of a partnership and the impact?
Yeah, so the Drishti is we have been after the RSSDI because one of the challenges is in getting the diabetologists to take the onus of diabetic retinopathy screening because they are the people who are seeing the diabetic patients and not the ophthalmologists. So if they can take up the onus of identifying the diabetic retinopathy among the patients who are walking into the clinic, which is not done in most of the times, I think it will go a long way in helping these patients, finding them early on. So I think this Drishti program is set up to ensure that we create these models in different zones. Like we have divided in India to 5 zones where we are central, north, south, and east, west. And so we have taken the central zone first as a sample to identify 2 diabetologists, 2 retina specialists, and connecting them in screening. So those patients, the retina specialists will help in training the diabetic, the technology technicians in the diabetic clinics to screen the diabetic fundus for the patients, diabetes patients. And those patients, they will use AI for screening, which Remedio is going to help in doing this. And then once those are identified, will be screened by the retina specialist. So this is the process. And then there will be multiple DR awareness programs that will be conducted for this process. So we are trying to create these across the country. So this way, this model can be taken up because this could be not just a screening model, but it could become even a business model for this for people. So it's a win-win situation so that all the diabetic patients are screened earlier. So that's the whole idea of having this Drishti weapon.
Dr. Kim, this is amazing on so many fronts. I'll tell you. Number one is just the concept of patient awareness is so crucial because just the patients knowing that such kind of technology exists to help them, they will start to ask for it. So I think with the Drishti program and the partnership with Sun Pharma Remedios, that you're trying to also educate patients about the availability of AI technologies like this, I think is going to be a very crucial bit for the success of the program, and also going to help in the eye health of the patients. And more importantly, I must say, and congratulate, of course, the team for the implementation of the tools. You're all stalwarts who have kind of shown the way to develop these algorithms in the country for retinal diabetic retinopathy detection. But I think when the rubber hits the road, you're truly kind of bringing this impact to the people at their clinics or their doorsteps. So thank you very much, Dr. Kim. A lovely, insightful talk, but many points of learning from what you've been able to show us through your experience. So thank you. I will bring you back in for the panel discussion shortly. Thank you, Dr. Kim. Now we would like to move on to our next speaker. It's my honor to introduce Dr. R. Venkatesh, the Chief Medical Officer of Arvind Eye Hospital, Pondicherry. And Dr. Venkatesh is going to be speaking on how AI can be used in vision centers and outreach programs. Dr. Venkatesh?
Thank you, Dr. Vipin, for choosing this excellent topic for the symposium. So I'll be focusing more on how we do this opportunistic screening in vision centers and outreach programs, because Arvind has always looked at non-customers, people who can come to hospital, have all the means of coming to hospital in the form of support, in the form of financial support, but people who cannot come to the hospital, no, we need to reach them, the reaching the unreached. So we all know some of the anterior segment issues are easy to identify, like the cataract, refractive errors, or corneal issues. But most of the posterior segment diseases, which are fast growing in numbers, especially diabetic retinopathy, glaucoma, and age-related macular degeneration, these are quite staggering. The numbers, if you see, the problem which you see in 2020 is not going to be the same in 2040. The numbers are going to double. So this is the kind of burden which we are seeing, especially with the posterior segment diseases, which are much difficult to diagnose and also to manage if it is diagnosed at the very late stages. So it is not very easy because it's mostly asymptomatic. And there is kind of inaccessibility to eye care for most of the people who live in semi-urban and rural areas. And also we need specialized equipments and personnel to do some of the tests for these patients to diagnose these conditions. But the most important thing and the key for this symposium again is early detection. Because once you detect early, we can create awareness of the problem. We can manage much earlier so that we can preserve their vision and quality of life, which is very important for them. And this can help us to also adhere to the treatment for some of the chronic conditions like glaucoma and diabetic retinopathy and ARMD. So whenever we are looking at screening for posterior segment diseases, I think these three are very important. Is mass screening possible? It is possible, but it is very difficult. But we need to focus on high-risk screening, like what Dr. Kim said. Diabetologists, diabetic patients, if we can screen and find out the 20% at a much early stage, we can prevent them to going to those serious diabetic retinopathy, which can damage their vision. And then opportunistic screening of individuals who are seeking eye care for unrelated problems. Let it be presbyopia, let it be a cataract evaluation, let it be even a foreign body. Once you have removed the foreign body and when the patient comes for follow-up, you have to screen for eye pressure and posterior segment diseases. So that is what is called opportunistic screening, a comprehensive eye examination, irrespective of what their complaints be. And combining this posterior segment screening with other screening at all levels of eye care, either be primary, secondary, or tertiary. So I'm going to share with you some of the experiments, at least, which we have been doing in Arvind and also especially in Pondicherry. Now, where the vision centers were really created looking at non-customers. So these centers are in real semi-urban or even a rural area with a population of 5,000 to 10,000, with a surrounding village population of 50,000. We have created these small centers, which are 600 to 800 square feet, manned by 2 paramedic staff. One is called a kind of coordinator, and another person is the technician. So the main idea is to make eye care available, accessible, and also affordable. So these vision centers, now we have 118 vision centers across our system. Pondicherry runs 19 centers, which provide a permanent eye care service for that particular population. It runs from Monday to Saturday, 8 to 5 p.m. So this helps us to inculcate a kind of proactive health-seeking behavior. People need not delay for any of the problems, either be red eye or be defective vision or be a diabetic screening. We want to change the behavior, the health-seeking behavior of patients in that community. And we found that it really increases the uptake of eye care services. And thereby, we were able to reduce the backlog of blindness in wherever we have these vision centers. So we have 118 centers, almost covering 2 crore population of Pondicherry and Tamil Nadu. If you take the population of Tamil Nadu, which is roughly above 7 crores, almost 1/3 of the population is covered by these 118 centers. And in a year, we see almost 1 million outpatients. Last year was the maximum. We were touching 1 million outpatients. And what we see is when we start a vision center, 40% of them reach within the first year, and then 75% by the second year, and then by third and fourth year, 100% of people who need eye care in that particular population reach the vision center. And more importantly, 85% of the problem is taken care locally, and only 15% is referred for further investigations and care. So these 118 centers in the last academic year, 23-24, have seen close to 1 million outpatients. So of which 85% of the problem were taken care locally. Over a period of time, we have been kind of constantly changing. So this is the old way of fundus imaging, which you saw in our vision centers, using digital camera. It was so difficult to shoot with the 90D lens. Now we had a lot of innovations to do that. We usually capture a video and then take a screenshot and then upload it into the electronic medical record. Very cumbersome. And now we have fundus on phones for them, where it is very comfortable to take the image and upload. And from regular paper records, now we have electronic medical records. We have prescriptions signed by the doctor going to the vision center. And then it's very seamless again. And a lot of other things have been changed. We have given them eye care tonometer to measure intraocular pressure, a good RO chart instead of Snellen's chart, and several other gadgets which can help them, like an autorefractometer to do refraction if it is crowded. So over a period, we have also adapted these technologies so that in addition to just doing cataract and refractory error screening, we were able to identify sight-threatening eye problems and refer them for early care. We were able to significantly reduce the carbon footprint by reducing the travel of these 85% of patients who have taken care locally. And we started doing follow-up for our cataract surgery patients and other people who need follow-up care. So this reduced the cost for the patient, both direct and indirect cost. The indirect cost is something which is very important. It is the lost wages of the patient and also the caregiver, which is taken care when they go to a vision center. It's just a couple of hours trip. And when you diagnose any condition early and manage, definitely you improve the whole health economics of it. It reduces cost and improves the outcome for both the patient and the provider. Let's see how a vision center works. So this is a vision center which is located in a place called Kurinjipadi, which is near a big lignite corporation called Neyveli. So whenever the patient goes, they register through the electronic medical record. And once the registration is done, they charge ₹20 to do all the investigations, including a blood pressure, a blood sugar measurement. And then now when we have the non-mid fundus camera, the photo is taken by the coordinator. Before it was taken by the technician when it was mydriatic. With the non-mid, we have brought this to the front so that immediately they can take a non-mid image wherever possible. And then using the Meteor's AI, the report is generated and then it is synced with the EMR seamlessly. It just takes a few minutes. And once the patient finishes the registration and the fundus imaging, then he goes to the optometrist. So the optometrist is a technician who does a detailed evaluation. She's also trained to do slit lamp, applanation, tonometry, and eye care if needed for intraocular pressure. So she does refraction and she does a applanation tonometer, and then she also dilates wherever there is a need, especially people with cataracts and other corneal opacities. And then finally, everything is entered into the EMR and a telemedicine happens with the ophthalmologist. And whoever needs a drug prescription, it is signed by the base hospital doctor and they get a drug or a glass. Or if they need referral, they are referred to the base hospital. So what we have done is we have tried to see whether a routine fundus photography really helps in a vision center. So we randomize some centers, whereas they take wherever there is a need and a routine photography. And we found that when you do routine photography, there is an increased odd of referral, especially posterior segment diseases, when compared to the standard care where they need whenever it is needed. So we already did all these kind of work where we were trying to image and keep all those things ready for an AI to be implemented easily. And this is one work which we did during the pandemic. And now we looked at a data of 7.69 million outpatients. And if you see people coming during the lockdown period to the tertiary care centers were less than 40%. During wave 1 and wave 2, you can see wave 2 slightly it increased to 50 plus. But if you see these primary care centers where they can go by bicycle or they can go by a walk or a two-wheeler, where they don't have to get an e-pass to go, we had a significant attendance. We almost had 70 to 80% of patients even coming during the pandemic. So this shows how these vision centers can be so effective during some of these calamities. So from this, I'll just take you to outreach now, where every year we do close to 3,000 eye camps across the system. We see more than 600,000 patients and do more than 100,000 cataract surgeries. Most of our eye camps were kind of oriented towards cataract for many years. They were using Shiat's tonometer, paper charts, and then only people who need fundus were dilated, like patients with diabetes or cataract were dilated. Whereas we wanted to see how, again, a fundus imaging and a novel outreach can help our patients. So we did a clustered randomized trial just before COVID in Pondicherry. And then there were two intervention arms. One was the traditional eye camp and the other was the novel eye camp, which you'll be seeing in this video. So what we did was we took everything from the base hospital, including an electronic medical record. And we continued to do this after we saw the success of the system. So you can see the vision check is done, and then the vision is entered into the EMR using a tablet. And then all the doctor's examination and the findings of torchlight, and we had handheld slit lamp for them. And the refractionist, all the details of the refraction were again entered using an iPad. They had an eye cap tonometry to check the intraocular pressure, and this was again entered. And then finally, we used a handheld camera, fundus camera, to take these fundus image, and this image was also synced into the EMR. So the final doctor had an image in front of him. In an eye camp, it is very difficult to sometimes see the fundus because of the environmental conditions there. And finally, the patients who needed a cataract or a referral were referred to the base hospital, and rest were taken care there. So what we found out was when we did the imaging, the posterior segment diagnosis significantly increased just by imaging and the doctor grading it. Now, this led to making sure that all our outreach now have this kind of a novel way. And this we published some time back in ophthalmology, showing that you need to image the fundus in some of these outreach areas. And again, during pandemic, when people were not able to access care during lockdown, especially our glaucoma patients, we were really concerned. So we thought, why don't we take the technician to their home, do all the investigations, because now all the investigations are there in a bag. no, you need to do something like a visual acuity assessment, which you can do comfortably using a tablet or some other device like this. Now you have the peak acuity, and then an intraocular measure, IOP is measured using an eye care tonometer. And then we can do visual fields, using perimetry, which is based on virtual reality. Now this again, we have developed, it's called an intelligent visual field analyzer, and it helps you to see the visual field effects. As like less than 10 minutes, you can do both the eyes comfortably. And finally, a fundus image, which you see again, the fundus on phone, and the technician can take brilliant images and then upload into your EMR again for a teleconsultation. So we were doing all this and just waiting for a good AI to kind of take all those images to the next level, so that if there is some problem with the teleconnectivity, we can still give them a referral report. And we also try this in areas wherever it's possible, where like in malls, where we did in World Glaucoma Week. This was a mall in Pondicherry where we did a screening for a week, where we were able to detect a lot of DR and glaucoma suspects and refer to the base hospital. So by doing some of these experiments, we are really ready to incorporate AI into the images, what we are doing already. And what we did was we did a systematic review to see, and then look at how really AI is helping, especially with fundus imaging, especially for glaucoma. There were 36 papers on that. And then this period was between 2011 to 2021. And usually they had these two approaches. One is the logical rule-based approach, and the other was the machine learning, which is more statistical, which is more accurate, and it can be adapted to complex scenarios. But definitely it needs a large data sets and maybe a kind of a black box model. So this is what we wanted to study, and that is where we got into the Meteor's AI, and we wanted to see how it really works in our vision center. And you all know how this can easily, take the image, and then it also looks at the segmentation network. It gives you the cup and disc outlines and the vertical cup to disc ratio. In addition to that, the heat map also looks the surrounding peripapillary area. It looks for RNFL defects, peripapillary changes, which normally sometimes a grader can miss. So all these are taken into consideration, and then a referral is given by the AI. So what we thought was we wanted to see how it works in our vision center. So what we did actually is to compare AI results and the teleophthalmologist diagnosis, and then bring those patients to the base hospital for a glaucoma specialist assessment after all investigations. So we included 6 centers of the 19 centers we have in Pondicherry. And there was a comprehensive eye exam, like visual acuity, slit lamp, IOP, and then a fundus photo with the fundus on phone NM10. And the AI analyzed and looked for normal glaucoma suspect, and the teleophthalmologist reviewed the history through the EMR, and they saw the image and they were blind to the AI results, and they gave their own referral. They did not know what the AI said. And participants were flagged by either the AI or the teleophthalmologist as suspect or glaucoma, and were referred to the tertiary care center for further test. So what really happened was, if you see the referral glaucoma, when you compare with the telemedicine doctor or the teleophthalmologist, the sensitivity was 73% and the specificity was close to 98%. But if you see the AI with the glaucoma specialist in the base hospital, the sensitivity was as high as 91% and the specificity was also 91.6%. So AI was definitely doing better than the teleophthalmologists, who are the senior residents who are posted for this kind of an activity. And comparing AI versus the telemedicine doctor versus the specialist, you can see how big the difference is. So this made a real big difference for us, and especially looking at the false positive reference. So this became a big burden to us, because many of the telemedicine doctors, whenever there is a disc suspect, there are a big cup, physiological cup, or a notching, a slight notch, they used to refer. And these patients were unnecessarily traveling to the base hospital for their care. And then we had to reassure them that don't worry, there was a doubt and you can go back home. So this significantly reduced when we did look at how AI works in those vision centers. And this is the media, really picked it up, and they also said us how we can reach from 5 centers to all the 19 centers. Now we have deployed this AI. So what we have found out that it's got a very high sensitivity and specificity in detecting the referable glaucomas. And definitely there is a better agreement with glaucoma specialist when compared with the teleophthalmologist. And also it promises for glaucoma detection in primary care settings or in areas where you can Uberize an eye care or where you do screening outside the hospital in the form of outreach or even in activities which you do during World Glaucoma Weeks and other places. So the same thing, we are doing a prospective validation for the diabetic retinopathy patients, and the sensitivity of AI to pick up referable DR is really high. And majority of the over referrals we have seen is AI where there are mild cases, very small, it also picks up and refers. So this is an prospective work which is going on, and we are looking at the results for future publication. And again, I take this opportunity to thank Team Remedio and AOS for organizing this interesting symposium. Thank you.
Dr. Venkatesh, thank you so much for a very enlightening talk. And I think you've so beautifully touched based on the two other R's that we spoke of. The first R was relevance, the second is research, and the reach. So I think we've very beautifully showcased how research is important to back up, the accuracy of these models, which is Medio's AI DR, which is actually a CE MDR class 2, Europe and HSA and Singapore approved, and it's demonstrated robust performance in identifying referral DRs. And I think, Dr. Venkatesh, you also beautifully shown how diagnostics have gone from being immobile to becoming portable, and now they're becoming intelligent. So I think AI is here to stay. AI is here to assist ophthalmologists. And more importantly, AI is able to go where doctors cannot go, basically in terms of the unmet need. So thank you, Dr. Venkatesh. I'll come back to you during the panel discussion. And thank you once again for showcasing all the experience at the Arvind Eye Care System in the effective use of AI for the benefit of the population. At this point, I would like to invite our next speaker. It gives me absolute pleasure to invite Dr. Divya Rao, glaucoma specialist and the Chief Medical Officer at Remedio. And the title of Dr. Divya's talk is How AI Can Be Used in the Clinic. Dr. Divya?
Thank you so much, Dr. Vipin, for the kind introduction. And it is a real pleasure today to be a part of this exciting webinar. And I thank AIOS for this opportunity, especially being alongside Dr. Kim and Dr. Venkatesh, who have been really at the forefront of integrating novel technologies for improved patient care. So far, we have really heard excellent talks in terms of using AI in the screening context, where you are using this technology for those who don't have access to care. And today I will be discussing how this same technology has also relevance within the clinic. So here are my disclosures. Some of the content of this talk will be regarding AI-driven solutions that we've developed at Remedio and also published patents on. So I want to start with this. Can AI really catch what doctors have missed? I think this was a very interesting talk given by TED Talk given by Eric Topol, who is a physician scientist. And I really encourage all of you to listen to this talk because he made some very interesting statements. He said that there were 800,000 Americans every year who either died or had a severe disability due to medical diagnostic errors. And this is not what we often talk about. So can AI really help us catch these mistakes that could be often overlooked by doctors? So let me give you an example. So here we have 3 images, and I'll give you about 10 seconds to look at this. Which of these images do you think have glaucoma? Is it 1 and 2, 2 and 3, or 1 and 3? I'm sorry, there's no poll option here, but we actually did this in a recent cyber-side webinar with over 500 participants. And it was very interesting to note that a majority of them actually picked 1 and 2 to have glaucoma. In fact, it is 1 and 3 which are images that have glaucoma. It's very clear in the first image on the left. There is, you can see a superior notch with an RNFL defect that actually corresponds to an inferior arcuate scotoma. And the one on the right, even though has a smaller cup to disc ratio, has an inferior excavation with a superior arcuate defect with also changes in the superior RNFL. And the image in the middle, though has a high cup to disc ratio, has intact rims and no RNFL changes. So if you were to see this in a busy clinic with 100 patients, it's very easy to overlook this. So before getting into how AI can be used in clinics, I want to step back to understand how we actually take AI from research to implementation. I think Dr. Kim and Dr. Venkatesh have really set the context in terms of unmet clinical need and the relevance of which AI solutions to actually develop. In terms of diabetic retinopathy, glaucoma, and AMD, it's very clear that the public health need is immense. And once this is clear, we take the models through development and evaluate them in real world, and then take them to regulatory approval, and then deploy these models such that they fit into the workflow. And then, of course, we have post-market monitoring of these models, and then the clinical applications actually predefined based on the intended use of the AI solution. So as Dr. Vipin mentioned right at the start, if we have to summarize this, it's the relevance of the problem that you're looking to solve, taking that through research and development to actually develop these models, generating the evidence to actually show that these models are working well in the real world, and then taking it through regulatory approval. Now, if you were to actually implement these AI solutions, which we've managed to do successfully in India through taking it through CDSCO and CEMDR approval in Europe and as well as in Singapore, it means to say that we need to comply to all of these principles that are mentioned here. Machine training ethics, machine accuracy ethics, patient-related ethics, physician ethics, as well as looking into regulatory. So if we look at machine training ethics, what actually happens? So we look at large, diverse, unbiased data sets, which are truly representative of the population in which you're actually deploying the AI solution. Of course, the data has to be anonymized. We have to make sure that the algorithms are developed in secure platforms so that data privacy is met. We look into what actually goes into the data training to ensure that there is transparency. Robust ground truth, as you know, is very important because this is what the AI actually learns. Then you go through a process of data cleaning and processing to make sure that it is very representative of real world data. And you also have to look at explainability of these models to the extent possible, though they are often a black box. And when it comes to machine accuracy, it's not only about looking at how these algorithms would do on well-curated data sets. We have to go a step beyond that. To actually implement this, we need to see how they do in the real world through prospective studies, and then understand what is the performance of these algorithms. Do they compare well to the current standard of care that you actually see in the clinics? And then make sure that these algorithms meet predefined endpoints that are set out by the regulators. And once these are deployed, actually monitor them over time to ensure that the continuous accuracy is well documented. And through all this, it's very important to make sure that you're actually looking at patient benefit and improve patient outcomes and ensure that the AI solution that is being deployed is actually providing equitable care, despite where you're going to actually deploy these algorithms. And through this process, it's important that you have the trust of doctors and physicians that you're actually providing them tools to improve the diagnosis that they're able to make. And of course, one of the most important is now looking at how you can actually go past the regulatory, because what they are looking at is safety and efficacy of these algorithms to make sure the benefits always outweigh the risks. So the applications of AI in ophthalmology is numerous, right from anterior segment to posterior segment. All of them have been really well researched. And because it's a heavily image-based specialty, every possible modality has been looked at, right? From fundus imaging to OCTs to OCT angiography and ultrasonography and the like. So, but broadly, if you look at it, what are the approaches that have been used? Either these algorithms look at a classification task where they look at automating diagnosis as a yes or no, or they look at segmentation tasks where, say, on an OCT scan, you're actually quantifying what these biomarkers are, or you use sort of transfer learning techniques where you use pre-trained algorithms and see how that can be utilized to look at prediction models, or use training from one modality to another modality to actually look at prognosis. So broadly, if you're looking at what is the utility of AI within the clinic, you can actually triage patients early to move them to specialist care for management. You can actually standardize the diagnosis, and this is very important in high volume setups and when there are no sophisticated equipment like, say, OCT and visual fields, and you're looking to monitor patients over time. And I think this is where the real power of AI comes, because it can actually look at longitudinal data over time and integrate all of this, look at multimodal imaging data, and actually provide predictive analysis. For example, if one eye is affected with exudative AMD, how soon will the other eye be affected with exudative AMD? And there's good research to show that AI is doing pretty well out there, or trying to differentiate fast and so slow progressors in glaucoma. Now with large language models, they're also used to improve workflow efficiencies within the clinics, where patients can actually use chat box and pre-screen so that they know which specialty they need to actually go into, or they can even be used throughout the patient journey, where they actually provide reminders to patients to take their medication, or they can be used to provide patient education and awareness based on the diagnosis. And it is also useful for training and education, as we will see as we go along. And last but not the least, what we're looking at is how can imaging of the eye be used for systemic disease risk. So today I'm going to only focus on these aspects, on where the same screening algorithms that are used outside of the clinic, what relevance do they have within the clinic? So it's very clear, if you look at this pyramidal model, LBPI pyramidal model of integrated model of care, or if you look at any other hub and spoke model, the AI outside the clinic can be used in community screening. And now let's look at how the same AI can actually be used by general ophthalmologists or even specialist ophthalmologists. So I just wanted to touch upon how this will be integrated and what is the sort of workflow that you will look at. So outside of the clinic, in the community of vision centers, like Dr. Venkatesh pointed out, nurses or healthcare workers would actually capture images, run the AI algorithms, and here it would be an autonomous use of the AI, where the AI would make a decision and would refer the patient, unless, of course, teleophthalmology is used. But within the clinic, this is a bit different, because here you have ophthalmologists who are actually seeing the patient. So images can be captured, and the AI results act as an assistive tool to give more information to doctors to make better choices, better decisions. So if you look at how AI can be used within the clinic, it can definitely help in triaging patients to specialist care. And what evidence do we have so far about this? Dr. Venkatesh has already touched upon the glaucoma AI, where there are actually two networks. One is a segmentation model that gives the VCDR output, but more importantly, there's a classification model that looks beyond cup to disc ratio for actual structural abnormalities of the optic nerve head and RNFL changes to make a referral decision. So we conducted multiple prospective studies, and when we looked at this data, over 700 patients across Narayan Nethralaya, Arvind Eye Hospital, and LB Prasad, we saw that when you compare the AI to actually standard of care, which is within the glaucoma clinic, a full battery of tests, right from clinical examinations all the way to visual fields and OCT, the AI had a very promising performance of 88% sensitivity and 91% specificity. Beyond this, we also looked at multi-ethnic data on a very large data set of over 50,000 patients coming from a high-risk diabetic group from the US. And it was very heartening to see that the same level of sensitivity and specificity was also maintained. So what does this actually mean to us? So if you actually look at this graph, if you look at individual tests for glaucoma, that is tonometry, visual fields, or OCT for RNFL thickness or GCC analysis, you will see that the AI actually provided the best balance in terms of sensitivity and specificity compared to all of these individual tests. Here, I just want to highlight that what I'm trying to say is individual tests, but not all of these tests combined. And where it comes to is that we are not looking at it as a replacement for standard of care, but how this can be used to provide more data to an ophthalmologist to make a diagnosis. So when we looked at a subset of these prospective studies on 200 subjects, where the diagnosis was actually coming from standard of care, we compared how the AI that looked at fundus images alone compared against glaucoma specialists who also had the same set of images. And what was very interesting was that the AI actually picked up 94% of glaucoma cases, whereas the glaucoma specialist looking at the same fundus images was only able to pick up 60% of the cases. So here is an example where the AI detected that the left eye with a VCDR of 0.6 had referable glaucoma, but the consensus image grading of 3 glaucoma specialists said that there was no glaucoma. The AI said that this patient needs referral. And as you can see, the right eye was pretty much normal, but on the left eye, corresponding to the inferior RNFL loss, there's an early superior arcuate scotoma, which is also seen on the OCT as a inferior RNFL defect. So similar to this, we also looked at how the Meteos AI algorithm for referable AMD did against standard of care. Here, what we mean by referable AMD is intermediate and advanced disease being flagged as positive. And here, standard of care was wide field imaging coming from a standard desktop system along with OCT. So on a 500 patient prospective study done at Arvind Chennai, the sensitivity was 91% with a specificity of 85%. And the sensitivity, in fact, to detect advanced glaucoma was over 96%. So clearly, AI can help standardize care. And especially if you're a general ophthalmologist and don't have access to, say, OCTs and sophisticated software, these AIs can give you more information to make better decisions. We also went a step ahead. We've done some machine-to-machine learning models where we looked at SDOCT derived ground truth, and we trained fundus images to actually predict RNFL thickness as well as predict retinal fluid on fundus images. And these are very promising and again can be very useful for general ophthalmologists who may not have access to OCTs. And it has been shown in several studies, like the 1.8 here, where the sensitivity of these algorithms to detect fluid on 2D images was similar to that of a specialist with a much, much higher specificity, in fact, twice as much. We've also conducted certain pilot studies at LB Prasad in Hyderabad, where we have used the portable handheld device along with the glaucoma AI for photo documentation, even in childhood glaucoma cases and JOAG cases, juvenile open angle glaucoma cases. And it's shown that this is definitely feasible. We've gone a step ahead and even used this under EUA in congenital glaucoma cases. And so far, as my mentor, Dr. Sirisha, pointed out, there was no way to actually capture these images and monitor them over time, because we know that reversal of cupping is possible. And here, as you can see, the AI has actually picked up in the right eye an inferior rim excavation, and on the left eye, a bipolar rim thinning, which was also evident on the visual fields. Now, lastly, I just wanted to foray into what we are doing next. We're looking at eye as a window to detect systemic disease. As we all know, the eye is the only organ where you can actually look at vasculature as well as neural tissue non-invasively. And AI looks at a lot of patterns that is not even visible to the human eye and is able to pick up newer biomarkers called as oculomics. And there is very good research out there where we can actually look at estimating either risk factors or detecting diseases themselves or pick up newer biomarkers. And this is an area that we are actively exploring, and we're looking at coronary artery disease and chronic kidney disease. And to an ophthalmologist, what this means is that going forward, this will empower them with tools in providing not just comprehensive eye care, but comprehensive medical care. So I just want to end with these two statements. Responsible AI technologies developed through ethical frameworks and evaluated in the real world, while understanding its limitations, present an opportunity for a paradigm shift in eye care by augmenting an ophthalmologist's diagnostic capabilities and hence move towards more precise, accurate, economical, as well as equitable care. And I thought the last one was very relevant, though it comes from radiology, but I think it's very relevant even in ophthalmology, where while AI for imaging will not come all at once, early adopters of AI in their practice will be future leaders in healthcare. Thank you so much for your patient listening.
Thank you, Dr. Divya, for kind of showcasing the spectrum of the usage of AI in general ophthalmology. But of course, you've taken it one notch higher to say the eye definitely is a window into what you can look beyond the organ itself for systemic diseases and other disorders. But I think more importantly, you've touched base the important aspect of regulation, because no matter what we do with science, it's also important that when it needs to be scaled, there are certain aspects in terms of regulatory authorities approvals that need to be taken. And I must definitely share that it is definitely a milestone for India that Meteor's AI is now CIDSCO approved, which is the first AI model that's approved by the regulatory body in the country, which again is a prominent step forward in our journey to be able to take these models to scale to reach the unmet need, right? And to basically ensure that these actually go to the point of care testing. And I think in summary, we spoke about relevance, about the identification of what AI algorithms so beautifully, showcased by Dr. Kim in terms of the diabetic retinopathy and how the screening guidelines have identified. We've looked at research with Dr. Venkatesh talking about the accuracy of the models and also Dr. Divya. And we also looked at regulation and of course the reach of these models actually being used right now. So this is not the future is here already. We are actually implementing these models in care practices. And it is definitely to empower ophthalmologists and allied healthcare professionals to be able to reach the people for early detection of these sight-threatening disorders. So this leads to reliable recognition of sight-threatening eye disorders for referral of those patients. So those are the other 3 R's, is reliable, recognition, and referral. And also, as Dr. Kim mentioned, it's a win-win for everyone, even for diabetologists to be able to look at this as a tool to be offered as a service to patients. So revenue also. So it's a win-win for both the patients and the care providers. And of course, the cost benefit and the cost effectiveness of these models will only kind of grow more efficient as we move on utilizing them. So at this point, I would actually like to thank all the speakers. We will be shortly getting into the panel discussion. But before that, I would like to invite Mr. Saptarshi Mukhopadhyay, who's a senior product manager at Remedio and is a techie with a purpose. And he'll be adding a bit of light on the vision about the unique partnership between Sun Pharma and Remedio. Saptarshi?
Yeah, hi. Thank you, Dr. Vipin. So, good evening, everyone. We had an excellent session where we learned about the critical relevance of DR screening and the use of regulatory approved technologies to reach the masses in need. And as has been repeatedly mentioned, today we know that 100 million people are at risk of blindness or visual impairment due to chronic retinal diseases. Today, the urgency is not just in screening, but in moving patients towards immediate treatment by our eye care specialists. Moreover, with only 15 ophthalmologists per million people in India, we face a huge healthcare burden where eye care accessibility is poor. Unfortunately, in India, where 100 million people are at risk of blindness, eye health is still not a priority. To address this, it is crucial to make screenings available where patients are and not wait for the patient to voluntarily walk in for an eye checkup. It is also important to offer simple to use technologies that can be used by anyone, even physicians and diabetologists, who can then support in realizing the overarching goal of reducing preventable blindness. And that's exactly what Sun Pharma and Remedio aim to achieve over the next 3 years. That is, making screening more accessible for patients with chronic conditions, both at diabetologists and ophthalmologist clinics. Our common purpose is to encourage patients to seek timely specialist care through connected care, a unique eye care model that accommodates the challenges faced by all stakeholders in delivering eye care right from awareness to treatment, while connecting all involved stakeholders. In just the last 6 months, I'm happy to reveal that through our partnership with Sun Pharma, we have screened 48,000 patients for referable diabetic retinopathy and more than 9,000 for referable glaucoma. Over the next 2 years, Sun Pharma and Remedio aim to screen approximately 15 million patients by equipping diabetologists and ophthalmologists with cutting-edge solutions that screen for all leading causes of blindness, DR, glaucoma, AMD, and soon even for systemic conditions such as cardiovascular and chronic kidney disease. Collaborative approaches like connected care are the future. By continuing to work with the broader ecosystem, we aim to develop solutions that extend beyond eye care, positioning the eye as a gateway to overall wellness. Together, we can envision and build a healthier tomorrow for our country. Kim mentioned, we are confident that initiatives like Drishti will play a key role in eliminating blindness caused by diabetic retinopathy. We will continue to collaborate with medical bodies such as the All India Ophthalmological Society, Vitreoretinal Society of India, and the Research Society for the Study of Diabetes in India, working together to establish clear guidelines that boost screening efforts in India. By uniting the two key stakeholders, ophthalmologists and physicians managing diabetes and other chronic conditions, we can significantly enhance eye care together. Thank you, everyone, and request everyone to visit us on LinkedIn for more updates on our path-breaking AI. Thank you.
Satoshi, thank you so much. And again, I must say that this is a very important webinar as an update to the nation, on how doctors, how the industry, and how these point of care devices are going down the path of ensuring that we build trust in terms of what we are able to screen. And also all of this AI tools are to assist and empower ophthalmologists and care physicians to be able to identify patients at risk. So thank you, Saptarshi. Looking forward to more updates as we continue to expand the program. So at this point, I think we do have a few questions that are coming up from our attendees, and with the kind permission of our speakers, we'd like to have a short and a crisp panel discussion. And then I would probably direct the first question as a general question to all of our speakers, and you can probably give me your opinion on it. Most of the times the world is talking about AI replacing people at scale, right? And it says that, hey, AI is going to eat your job, it's going to make you jobless and stuff and everything. So people also, at least on the medical aspects, right, the clinical acumen, people also now crib that, are we losing our clinical acumen because devices are coming in? And if AI comes in, what is our relevance if it is going to be much better than us? So any broad thoughts about replacement? I think it's not. But any broad thoughts about how clinical acumen, will it grow? Will it decline? Or it will stay the same? So just I would love to have a few thoughts from our speakers. Thank you.
Vipin, even in the work which I was sharing with you, right? The tele-ophthalmologists who are our residents who are doing the teleconsultation, when they see the EMR, all the findings, the intraocular pressure, fundus image, everything, then they take a decision of referral, where their referral had a lot of overdiagnosis, whereas the AI's diagnosis were much more accurate in looking at the different picture, not only the disc, but also around the disc, like what Divya was pointing to. It was not only the segmentation, but a lot of other details it was looking at. So what we found was when the AI report was blinded, they were not aware. But now we are sharing the AI report to them. By sharing the AI report, and I was chatting with some of the residents even recently, they're saying once the AI says refer, now they are looking at the image again carefully and seeing what they are missing. Is it that subtle notch or that RNFL defect or the peripapillary change there? So I think somewhere it is getting a complementary, for teaching also. So that is what I understand, at least from the work which we did. I particularly did this study to see why there is so much of overdiagnosis or why so many false positives are coming to the base hospital and whether AI can help me. They were able to detect real glaucomas, but there were a lot of false positives. But now it has reduced that, and also it has helped to facilitate the residents to learn better. So that is one interesting factor which we also kind of wrote in our discussion in that paper. Yeah.
Lovely, Dr. Venkatesh. And I mean, that also kind of shows that AI is also going to be an educational tool, just to go back and actually see what they missed. Any thoughts from Dr. Kim and Dr. Divya?
I think I completely echo what Dr. Venkatesh said. We'll have to look at it as how it can be complementary, especially if you think about education. And if I look back at my days of glaucoma fellowship, right, you'd wonder initial few days, what is a notch? What is an excavation? What do you mean by vertical cup to disc ratio, right? Now, if you are actually able to visualize that and learn better from it, it will help you in the long term. At the end of the day, it's all when we're being exposed to so much technology, it's about your measured approach. At the end of the day, it will be a judgment made by the clinician at the end and how he uses this technology to improve the diagnosis that is being made. Just going back to the point on will AI replace ophthalmologists, I had a couple of thoughts. I think we are quite far away from it. If you think about it, one thing is that in a doctor-patient relationship, the emotional component of it is very, very important, right? And if either me or you would never want to be told by an AI that you have sight-threatening disease. What we are trying to do is give doctors an opportunity to have more of those conversations by giving them tools to make better diagnosis. And also when it comes to flexibility, right? When you think about AI, it is trained to do a specific task. It will give you a specific output. What if there's new research out there, right? A doctor can quickly adapt to changing guidelines and changing research. And I think the flexibility that the doctor has to make those decisions is far more easier, at least today, than compared to AI. So I think we are very far from AI replacing an ophthalmologist.
Dr. Kim, just
Yeah.
yeah.
I mean, there are two ways to look at it, Vipin. When you said, will AI replace the clinical acumen of the doctors? I think there are both pluses and minuses to it. Now, if you look at youngsters, you go to a shop buying something, and then just to calculate 25 plus 32, they take a calculator and start using it. It's a very simple maths. You lose the acumen. But I think what has happened is it has evolved into a much more important things because of those. I think the same thing will happen with AI trying to replace the regular parts in a much safer way, like finding what Venkatesh and Divya pointed out. I think we are bound to do much bigger things going forward. I think that's the evolution that will be happening. But I think saying today there's no replacement of AI. AI replacing the doctors is not the. I don't see that as a way forward. I think there is still a long way to go, where I think we'll keep evolving and start using AI in the right way, in the right context. I think that's how things will develop going forward.
Thank you, Dr. Kim. It's absolutely, we just want to reinforce the fact that it is complementary, it is assistive, and it is only going to help us deliver better care. And at this point, I would also like to, pose this question, the practical question of operational efficiency in the field, because as care providers, what we want is to reach as many patients as possible, to be able to early detect, diseases. So on the operational efficiency, there are two components. One is scale at which you are able to do community screenings. The other is in a busy clinic, can we use these tools to kind of cut down time? We are all now talking about, people talk about PROMs, which is patient-related outcome measures. But now people are also talking about PREMs, which is patient-related experience measures, right? So what is the patient experience when they come to, get eye care at our organizations or institutions? So for operational efficiency, some of your thoughts on how you've really seen the impact on the ground to reach more people, number one, and also the time that you are saving is also helping you reach even more. So just a few thoughts on how important it is for us to look at AI, increasing our operational efficiency also in the delivery of care. Thank you.
Let me go first. Yeah. So I think the way you see AI improving the way things do, I'm foreseeing like, the AI is going to help patients triage themselves when we are going to the doctors. I think we are going to be addressing those patients who really have pathology, than those screening these patients moving forward. I think that's how I think AI will be there in the, will be helping us in screening patients or in managing patients. That's how I see AI being used.
Thank you, Dr. Kim. Dr. Divya and Dr. Venkatesh, yeah, please.
Yeah.
No,
I think
when you saw Kim's presentation, he was talking about how the diabetic clinic's report was sent to the base hospital for somebody to read. And then it took almost 30 minutes to 1 hour to send back the report. So the patient is waiting there. He has finished all the investigations. He's waiting impatiently. Even though he's a patient, he is impatient there. But now with AI, they generate a report within a minute. And then they give him, whether you are referred to the eye hospital or not. So that is what he needs. He's not bothered where it goes, who is reading, when it is going to come back. So I think the whole experience changes there, right? So, and when your sensitivity and specificity is good, you are ready to use it. Then even a human grader doing it on the other side. That's what, wherever we have done outreach, we have seen that efficiency, but not actually in the clinical practice, because we are still not using it where we have the real consultants and specialists. So we are not able to really assess the efficiency of that in a base hospital, but definitely in an outreach setting or in a diabetic clinic like that, it has definitely improved the efficiency.
Yeah, I think the part on operational efficiency is very important, whether it's in the screening context or within the clinic. So as Dr. Venkatesh pointed out, in a screening context, when you have someone come into a vision center, it's usually someone who is on relying on daily wages, right? For him, every minute, every hour is important because he wants to get back to his work so that he doesn't lose that day's wages. So if you want to bring in operational efficiency, one of the ways that we've really looked at is how can you bring AI on the edge? How can you bring it offline such that you click images, you press a button, you get instant reports within a few seconds, versus what would happen typically in most AI algorithms where you capture images, it goes to the cloud and the cloud analyzes, it comes back. So there is always a delay. So I think we've been able to do this by leveraging on the iPhone processor. I think this really improves operational efficiency, especially in screening contexts, especially where there's no internet, right? And you have to rely on stable connectivity when you're using the cloud. But with this, you don't need internet connectivity at all. And the last part is, of course, costs, because costs become very significant when you use cloud-based architectures and you have to host these models on the cloud. It's no more going to be affordable. But if you bring it on the edge, on the device that you're using, you're going to be saving a lot of costs, making management more affordable. And when it comes to within the clinics, again, I think operational efficiency becomes very important, as Dr. Kim rightly pointed out. I think future would be where you'd be using chatbots, you'd pre-screen yourself and decide which specialty to go to. And we're also doing few early studies where we are looking at whether using this within general ophthalmology clinics can help triage patients faster. But these are still early days, I think, within the clinic. The relevance has been far more in the screening context.
No, thank you.
Vipin, you talked about PREM, no? So I think one of the things that AI can definitely bring in, I was mentioning about personalizing medicine. I think we are looking at, there are some of the things that we are experimenting on how fast we can get patients' data, specific data about the patient who has been visiting you for so many years.
Yeah.
It's very difficult to, go through the case sheets and all. Can, AI summarize the data for you? And even the process of data capture from the patient. As I mentioned, like the patients can help triage themselves. Patient can give the data. Like today, nobody goes to the bank. Today, you don't go to the airline counters to check in, to book your tickets. So can the patients come in when the patients come in, you have all the data about the patient right in front of you, kept just giving you the details. So that's what AI can do going forward. I'm sure that will make a huge change in how we see patients. They said, more importantly, personalized medicine.
Dr. Kim, you are definitely, laying down the vision for what we should definitely evolve into, because that was my next point that I was mentioning. I wrote about the AI pipeline, published it a few years ago as well, about a 7-step process. The first step is to capture data, and that is where Dr. Kim is, pointing out that digital capture of information for your patients is important. Like if you capture it, you benefit from seeing a pattern as they come back to you, in their life cycle of and their journey of care with you, right? And then you basically have structured versus unstructured data. It's not just any data that you put into the system. You need to have a bit of a structure. Then you build your AI models on top of the data sets that you have. But most importantly, what you've seen today in the webinar is that organizations have brought it back into the point of care. You're using the AI in regular practice. And that is the most important step. It is not just about building an algorithm. It is actually integrating it back into the EMR or the devices for people to use it. And then the fifth bit is basically, people have been talking a lot about this, is ethical and trustworthy AI, right? The concept of how ethical is the AI, how trustworthy is the AI, is only made more stronger with published research and experience, right? And you put it out there that this has been the experience of us of the use of the models. And then more importantly, the clinical validation of what actually happened, and Dr. Kim has shown that 647% increase in terms of them identifying diabetic retinopathy patients that they would have not probably done in the conventional methods. I think itself is a statement and a testament to how these tools can really empower us to catch these patients pretty early on. So I think that is, so thank you for your thoughts. And also more importantly, Dr. Kim, I think there is a huge opportunity for us, as you rightly mentioned, is to look at how each patient has behaved temporally in their journey, for you to basically have that insight that is, encapsulated by the algorithm to tell you that this is what is a personalized plan or a personalized treatment that can be offered to them. I think definitely the future lies there. While we've all been talking about, the goodness of AI, the benefits of AI, and all the other aspects, I would also want our panelists to basically also share a bit about the challenges. Right? It's definitely not a rosy journey, right? I mean, there are challenges, there are limitations. So let's spend some time from each one of you to share your real world evidence and real world experience about the challenges that you faced and how you overcome them also, because you all have showcased where the impact has happened, but it has not come there without its share of challenges and hurdles which you have overcome. So it'll be great for our attendees also to hear about the limitations and challenges that you've overcome as well in the journey so far. So thank you.
Venkatesh.
You can go first.
Well, I would say the challenges is not so much in implementing or using the AI, but more so in like the compliance to the whole process. I told you that that we screened almost 1 million patients in the last one since we deployed the AI. But if you look at the number of patients that we could get them to come and actually have those identified as referable DR, the numbers are very, very, very small. So those are the challenges that we see. Though we identified them, we scaled them up, but bringing them to the clinic or bringing them to follow up has been a big challenge even today. The other challenge has been in acceptance of using AI among the physicians or the people where we have launched these screening modalities. It's taken some time for people to accept how AI can, because we have to do, we did a lot of validation. And we continue to do the validation on these patients regularly, even though it's an approved AI algorithm, but all those patients referred as DR, we continue to evaluate. But we don't know how long we can continue to do this because of the increasing number of cases we continue to identify. So
thank you, Dr. Kim. Thank you, Dr. Kim, for some real insights. Thank you.
I strongly agree with Dr. Kim, because closing the loop is very important, which is a big challenge for us, even not only with AI, even before. When we were referring cataract patients, they were not coming to the base hospital. Then we decided to bus them to the base hospital for surgery. They had a lot of other limitations. They don't have support, they don't have money, they don't have time to come. So we had to take care of all those barriers to bring them for surgery. The same thing happens now when you screen for DR or glaucoma. You have diagnosed 100 people and there are only 20, 30 coming to the base hospital for care. And how do you close the loop? Maybe we have to think of innovative ideas to get to them, to the centers, with the specialist, and then find out the real sight-threatening ones and get them for care. So we need to really see how we can close the loop. The AI works brilliantly. The other challenge, which at least now we see, is when we are expanding the number of centers, we need trained technicians again. even though it is non-bid and several other tests they have to do, training these technicians optimally is another challenge which we see. Now they are quite young, they are adaptive, but still we need to make sure they are well trained to do some of these tests and also imaging in a perfect way.
I think Dr. Venkatesh and Dr. Kim have pointed out beautifully in terms of what are the challenges at the time of implementation and referral. I think the models that we are looking at, where Dr. Kim is actually leading it in terms of the iDrishti model, how can you connect back from the physician to the ophthalmologist once they've been detected? I think those are some things that we need to see. We can see if software can actually help. We can see if tools can be provided to the patient in terms of increasing awareness and education on that front. But I also want to touch upon briefly in terms of what are the challenges that we see technically while developing AI themselves and some of the regulatory hurdles as well. So if you look at it, AI development requires large data sets with robust ground truth, needs to be very diverse so that it's applicable in the population that you're going to use it in, and access to this data is not simple, right? So there are challenges, right, when coming from data sets to the type of models that you want to use, because you have to work backwards from the constraints. So if you have to deploy models in the community that work without internet, the type of architectures that you choose will also be relevant in that context. And then if you look at what the regulatory looks at right now is how you're going to deploy a model once it is frozen, right? That means you develop a model, you test the model, and then you deploy it, right? Moving forward, what would be even more effective is if we are able to deploy models that can be continuously learning with the new information that it gets from the field, because this allows the model to be more current and learn from the biases that it might see when being deployed. But right now, the regulatory frameworks don't really allow for it. Maybe now CDSCO actually has looked at it, has a more forward-thinking approach. It does allow for adaptive learning for diabetic retinopathy at least, but hoping that this expands to other indications as well. And I think one of the things we also have to be cognizant about while using AI is right now, a lot of them is very disease specific, right? It's either for diabetic retinopathy, and that's the first one that has been approved even in the West. But what we're looking to do is to bring in all sight-threatening conditions so that the algorithms are not very disease specific, and you can get algorithms to work on multiple sight-threatening conditions. And what we also need to look at is intended use of these algorithms, right? They need to be used in high-risk groups. You don't want to be using a diabetic retinopathy algorithm on a 30-year-old patient who has no diabetes. So I think even awareness of the end user in terms of whom they're using it on becomes very important so that your chances of misdiagnosis is much lower. So those are just a couple of additional points.
No, thank you so much, Dr. Divya, and also Dr. Kim. I think the Drishti program, as you rightly mentioned, patients coming back to the base hospital, or even patients referred by diabetologists, are they actually reaching ophthalmologists, right? And how I think through your awareness aspects of the program, how do we really, impress upon the patient that it is important for you to now go and actually get a consultation done? I think also might be another interesting experience for us to see how that pans out. Maybe there are challenges in a rural versus an urban setting. That time will tell for us in terms of the access or the health-seeking behavior of patients more importantly. So I think that program will throw some new insights. I do have a question. Specifically talking about reimbursements, right? We are all talking about screening. There's a cost involved to it, and our national bodies looking at influencing insurance companies to be able to provide for this. Like, where is that money going to come from if you really want to screen? Any thoughts on what is the current landscape of us ensuring that people, if they want to use these tools, is there huge costs involved, or are there any kind of plans for reimbursements? Kind of a general overview. So that's a question that we've got. Thank you.
I can go first. I think you brought up a very important point there, Dr. Vipin. I think reimbursements are very important to make this sustainable. Actually, a lot of cost goes into development and R&D of these models, and we also need to look at how this would be sustainable for the ecosystem, right? And unless there is reimbursement and incentive for the end user, it's not going to be a sustainable model. So I think in that direction, there has been some movement through the Ayushman Bharat. There is reimbursement now that is there for both diabetic retinopathy screening as well as glaucoma screening. And we really need to see how this takes off, because at the end of the day, all of these models are really good. We have shown good research that they can improve patient outcomes and be beneficial. But the willingness to pay has really not been there to make this sustainable, and we have to really work towards how we can make this possible. Ayushman Bharat is one thing. The other one that you rightly pointed out is insurance companies, because at the end of the day, if you catch the disease early, the payout at the end would be much lesser, because the complexity in treatment is going to be far lesser if you detect them early. So I think these are two pathways. We are making some progress, but I think a lot more needs to be done.
Ayushman Bharat is paying only for the DR screening by the ophthalmologists, not for the AI use. So now, but this DR screening has definitely been a business model. Like, sure, you may be aware of. Well, Dr. Sendil from Chennai has done a wonderful business model, created a business model, DR screening, pan India. That is, in fact, that has helped him to move away from his practice to start a separate business in DR screening. And so there are ways that people have found to make it sustainable. But with the advent of AI, we still have a long way to go.
Thank you, Dr. Kim. Thank you. Dr. Diri, I'd like to bring you in, briefly to talk a bit more about the Meteor's AI, and what it is, just kind of a summary of the AI algorithms that are being offered. Can you just throw some light on it?
Yes, sure. I think a lot of it was captured very well during the talk. So Meteor's AI that we've developed works offline on our smartphone-based fundus camera, that is the Remedio FOP NM10. And essentially, you capture images with a click of a button. You can screen for multiple conditions: diabetic retinopathy, glaucoma, and AMD. And all of this runs offline using the iPhone processor and does not require cloud-based inferencing or internet. And within a few seconds, you can get a report for referable forms of disease for diabetic retinopathy, glaucoma, as well as AMD. And now we have regulatory approval for the diabetic retinopathy algorithm in India, Singapore, and Europe. And moving forward, we are looking at regulatory approvals for the other algorithms as well. And I think the regulatory bodies themselves need to, the frameworks need to be set for these other algorithms, because that's not currently there yet. What is it that you're looking at as endpoints for making glaucoma or AMD or any of these new algorithms available needs to be thought through and discussed with regulatory authorities, to make them used widespread.
Thank you, Dr. Divya. And of course, we will be shortly concluding the webinar, but I would want to bring the attention of our attendees back to the title, is AI protecting vision. More importantly, how is it going to really help us in early detection? And of course, it's a revolution. It's not that this is the future. We are here in the present. It is being used. You've seen some fantastic examples from the Arvind Eye Care system on the use of AI at reach and at scale. So we are here, and it is here to stay. And it is for us to be able to take this leap together, to be able to fully, I think, realize the potential of what these tools can do for us to be able to early detect these silent sight-threatening diseases. With that, I would like some final thoughts from each of our speakers before we conclude the webinar this evening. Any final thoughts and comments from three of our panelists? Thank you.
Thank you. But I think one of the things, like, as everybody, I mean, has this perception that AI is going to replace. So people have to get away from that and try to understand, people call AI as the new electricity. You can't live without electricity today. And that's what is going to happen. And people have to realize how to make harness the best use of AI. Divya pointed out about the instances, the importance of using AI in the right perspective, in the right way, so that, we have better outcomes for the patient. So people need not be worried about AI replacing them, because it can never happen.
I think
humans are,
also.
yeah. Go ahead. Sorry, Divya. Go ahead.
Yeah, no way. I completely echo Dr. Kim's thoughts. I think AI is there now in every walk of life, and we need to really embrace this technology and be open to using this technology for better patient outcomes. If this technology is there to help us make better decisions, keeping patient outcomes central, and we are able to prove that, then I think we should be open to start adopting this technology for that.
Yeah, in simple words, it's complementary now. No, it's not going to compete with the human. It's going to be complementary. So we have to see how we are going to complement each other. But if you complement each other now, I think there is a brighter future. And Divya beautifully said, if people embrace, they are going to be leaders for the future.
Well, with that, I would really want to thank the leaders of the future who are already setting the path for the use of these tools for the benefit of our patients. I'd really like to thank the All India Ophthalmology Society, the scientific committee, Dr. Kim, Dr. Venkatesh, and of course, Dr. Divya, Sun Pharma, and of course, our team at Remedio for helping bring this webinar together. I would like to definitely reiterate that we are at a very important milestone where these tools are now approved, and I think now as end users we have to take that leap together to kind of build the trust of using these models for the benefit of our patients. With that, I would really like to thank all of our attendees as well for joining us this evening. We hope you've had a insightful understanding from the wonderful experiences, real world experiences that we've been able to showcase this evening of the use of AI for protecting vision. So thank you once again for joining us this evening. Thank you.
Thank you.
Thank you. Thank you so much, Dr. Vipin.
Thank you, Dr. Kim, Dr. Venkatesh, and Dr. Divya. Thank you.
Thank you, everyone. Bye.